afternoon, everyone, and welcome to our special edition webinar, Cuddles in Labor and Delivery. I am very grateful and I'm very honored to welcome today two extremely knowledgeable, very experienced clinicians from the UK, Dr. Paul Clark and Dr. Paul Coley, who are basically doing this webinar for us today. So before we start, I would like to quickly check if the attendees can hear us, and you can raise your hand to show that you can hear us. Perfect. So we have a few hands. So excellent. So a few organizational things. The webinar is being recorded, and the recording would be made available with some modification. We need to remove some patient data at the later in time. Also, there are three handouts. If in the handout section, you can see it on the right-hand side in your GoToWebinar toolbox. There are three handouts that you can download. One handout is the article that Dr. Clark and Dr. Colley worked on that also has the title of the cuddles in the labor and delivery room. And also there are two figures that Dr. Colley is going to be referring to in his lecture. So before we start, I would like to just quickly introduce myself and our esteemed speakers today. My name is Margarita Singer, and I'm the Regional Marketing Manager for Dräger, supporting neonatal care. And today we have a special edition webinar, which is a part of our digital neonatal nursing course that we are currently running online. And I would like to welcome, as I mentioned, two very experienced clinicians from the UK. Dr. Paul Clark is um, has done his undergraduate medical training in the University of Manchester in the UK, and he graduated in 1990. His neonatology training was done in Salford, in Manchester, and in Liverpool, and also in Canberra in Australia. And he has been a consultant neonatologist at the Norfolk and Norwich University Hospital in the east of England since 2005. He has a Doctor of Medicine degree awarded by the University of Manchester for his 2008 thesis on the vitamin K status of preterm babies. And in 2017, he was made an honorary professor of the University of East Anglia in Norwich, UK. Professor Clark has a keen interest in clinical research and neonatal medicine, and he has more than 100 original research publications. And he is an advocate for early delivery room contact between parents and their newborn premature babies. And that is exactly why we're having this webinar today, to address the importance of early cuddles in the labor and delivery. And our second speaker, Dr. Coley, studied medicine at Guy's, King's, and St. Thomas Hospital Medical School. He completed his postgraduate pediatric and neonatology subspecialty training in Cambridge, Norwich, and Bristol in the UK. And he has clinical and research interest in optimization of early newborn care, in thermoregulation, and he also authored the first hour of care neonatal manual for the East of England Regional Neonatal Network. Dr. Coley is currently a research fellow working with the Centre for the Developing Brain at King's College London and the Evelina NICU at St. Thomas Hospital in London. His current focus is research investigation of novel means for non-ionizing study of perinatal brain development and neonatal injury. So our speakers are extremely knowledgeable and experienced in the topic of management of extremely preterm babies and extremely low birth weight babies. And today we're very excited to talk about the importance of parental contacts in the labor and delivery to really support the brain development and to support the development of the babies also further in the NICU. And before we start with the lecture, what I would like to share with all of you is a very special video that we have from a parent. And Dr. Clark, maybe you can just say a few words about this video and why it's so important to show it today, to start this webinar with this video.
Thank you, Margarita, for the very kind invite. Thank you to Dräger. Just like to say, I've got no conflict of interest here. I've no connections with Dräger, and we're very grateful for the opportunity to present to you. So the video, yeah, I think this is an ideal way to kick off our presentation. It's made with the integral help of, it tells the story of Emma, who's a parent I first met 15 years ago. She's a wonderful parent, and she's told her story. She's helped us with this project, and she's been instrumental in giving the parents' perspective of why it's so important that newborn premature babies get that early contact with their parents. So this video will speak for itself, and it will very nicely open up the way for us to give our presentation from the non-parental perspective.
Thank you, Dr. Clark.
They say from the first time you hold your baby, you will never be the same. Your life changes. The love you feel and the emotion is overwhelming. When you have an extremely premature baby, you wish with all your heart that you could experience that flood of emotion the moment they're placed in your arms. You would give anything to hold them the way you have dreamt. Most mums of premature babies don't have the opportunity. They may have to wait weeks, months, or may never get to hold their baby while they're still alive. At 23 weeks pregnant, I was expecting twins. Charlie was shown to me and taken away to the neonatal unit as I was still in labour with his brother Jack. Jack had a more difficult birth, and it took some time to intubate him. This was extremely distressing for us. Once Jack had been stabilised, the consultant asked me if I would like to hold him before they took him to the unit. I instinctively knew this wouldn't be something I'd get to do again anytime soon. Holding my baby in my arms was one of the most special moments in my life. He was so tiny, so perfect in every way, and never in my life have I been so proud and felt so much love. I was completely overwhelmed with emotion. Would any mother turn down the chance to hold their baby for the first time? Jack died from an infection after only 11 days of life. The only other time I got to hold my baby was as he died in my arms. I still find it difficult to speak about to this day, but the cuddle I had when he was born is something I will treasure forever. Jack's twin brother Charlie very nearly didn't survive. It's been a long journey to get him where he is today. He's a happy, healthy and crazy little boy with so much character. He's now 14 years old. Since the birth of my sons, I've been told that being able to hold your premature baby isn't something that every consultant offers. And to be honest, this surprises me. I needed to tell my story to raise awareness about just how much that first cuddle means as a mum. 14 years later, and this still isn't common practice.
thanks to Emma for allowing us to share that. Emma often joins us for these presentations, but she sends her apologies she couldn't make it tonight. This was taken 2 days ago. So Emma ended her little video by saying 14 years later, it's still not common practice. Well, it's now 15 years later. Charlie turned 15 2 days ago. This is him playing on his electric scooter. So we're going to talk about what we mean by delivery and cuddle. In essence, it's a very simple thing. It's literally letting the parents hold their baby for anything from seconds to a few minutes. That's all it is. It's very simple. We don't need to complicate it. We can make it safe and we can make it as special a moment as we can for parents, but we should try and make it. So the concept is, for us as neonatal practitioners, nurses and doctors, trying to offer and facilitate the chance for the mother to cuddle her newborn before its neonatal unit admission. Now this needs to follow initial stabilization or resuscitation, if that's what the baby needs. We're talking about allowing a proper cuddle in the arms instead of just showing the baby to the parents, which is more often than not what happens. We should try and practice it wherever and whenever possible. We can do that irrespective of birth gestation. Now, in this talk, we're going to focus on the practice of offering the cuddle for extremely preterm infants, those less than 27 weeks gestation. Now, that's not because we only do it in that group, not at all. We do it for babies of all gestations. But logically, if we can do it safely and securely for babies of the earliest gestations, then there's absolutely no reason why we can't offer it to all preterm babies safely and securely. So I'm going to start by giving an overview of the practice and then present some feedback from parents.
Dr. Clark,
Yeah.
sorry, you're sharing your slides. If you could go back to the presentation, because we're still seeing the picture of Charlie.
I'm sorry. So presentation. You'll have to guide me here. Why? To my desktop. Let me just come out of this.
Let me take over.
Can you see
right and
concept and outline?
No, we currently still see the picture of Charlie. Let me just quickly try something. I'm gonna make myself a presenter again. Okay, and now I'm gonna give back to you. Perfect. Yes, now we can see the concept and the outline. Perfect.
Is the control panel blocking the screen? Can you just clarify that?
You can move it to the side.
Yeah, let me just minimize it. Okay, sorry about that. Okay, so I'm going to present an overview and then feedback from parents, and then my colleague, Dr. Corley, will take over, and it will go through the how to do it safely, and how we can practice it for the preterm babies that we care for. Is the slides advancing, Margarita? Should be the next one, family-centered delivery and care. Yeah?
Yes, family-centered. Yes.
So we're in a new era of family-centered care. Family-centered care is an approach to medical care rooted in the belief that optimal outcomes for the babies will be achieved when the family members play an active role in providing emotional, social, developmental support for their baby. So it's an approach to the planning, delivery, and evaluation of healthcare that's governed by mutually beneficial partnerships between us as healthcare providers, our patients, and their families. So we should be aiming to promote that partnership between parents and ourselves in the care of the baby. So I believe this concept can be extended right back to the delivery room, and we should be starting with the premise of family-centered care in the delivery room. So I believe that optimal health outcomes will be achieved when the baby's parents are permitted to play an active role right from the word go in providing that support that the babies need. And I think that enabling them to cuddle their baby and facilitating that is an ideal way in which we can promote that partnership between the parents and us as the healthcare professionals in caring for that premature baby from the very outset. If we can try and allow mums and dads the chance to cuddle their baby before the baby's neonatal unit admission, that will begin that partnership, and it can have many benefits. So in this talk, I'm hoping we're going to be able to show that the practice is feasible, that it can be done safely, and that it's beneficial for both the babies, the families, and us as the staff. And we'll propose that it can and should be practiced for most preterm deliveries. So why should we practice this concept of allowing the baby to be cuddled in the delivery room? Well, we know that the potential benefits of kangaroo care and direct skin-to-skin contact are multifold. They include physiological and behavioural benefits such as better thermal stability, better sleeping patterns, augmented breastfeeding rates, earlier discharge from the babies, and the babies seem to grow better and develop better. But there are also psychological benefits as well. So from the parents' perspective, they have more positive feelings towards the baby, lower maternal stress rates, and more confidence in meeting the baby's needs. So while for extremely preterm babies, the delivery room cuddle, as we practice it, does not usually involve complete direct skin-to-skin contact, because for us, the baby's already in a polythene bag and swaddled in blankets, we believe that some of the benefits may well be similar. Now, the European Foundation for the Care of Newborn Infants, which is a partnership between parents and professionals, they've recommended early skin-to-skin care to be of particular importance for very premature infants. And they've recommended initiating skin-to-skin contact as early as possible after birth as standard routine care. We now know that there's an early sensitive period and that the first minutes and hours after birth are really important for the formation of a tight bond between the mother and her infant. This concept is not new. It was first introduced about 40 years ago. The period seems to be characterized by a very special neuroendocrine situation, probably mediated by oxytocin and prolactin. But we do know it's a unique period of increased maternal sensitivity and responsiveness. So facilitating contact in this special period may improve the quality of maternal and preterm baby interaction and increase the chances of secure long-term attachment. So why should we practice the delivery room cuddle? Well, fundamentally, mothers and fathers indeed want to cuddle their newborns. Cuddling the baby in arms after birth is instinctive for parents, whatever the gestation of the baby. We now know that abrupt separation and removal to the neonatal unit of the baby who's already been with mother for sometimes more than 6 months in utero is traumatic. And that's presumably and probably mutually traumatic, not just for the parents, but for the baby as well. So we believe a calm and supervised initial cuddle is a marvelous opportunity for us to provide initial reassurance for parents, for us to meet them and for them to meet and form initial bonds with their baby, and for the baby to feel a first loving embrace. Parents in that special few moments, as I say, it's usually just a matter of minutes, sometimes seconds, sometimes 5 or 10 minutes, but it's a special moment when parents can touch and kiss their baby, touch their baby, talk to the baby, whisper to the baby, and they can get the first family photographs and video together. Everyone's got a video camera in their pocket these days, so it's easy to get that video, and we can help facilitate that as professionals. We can offer to take photographs and videos of the special moment on the cameras. Again, we also know that once the babies are admitted to the neonatal unit, they're effectively immediately incarcerated and shackled to multiple items of equipment, leads, monitors, tubes, and it becomes really, really difficult to get the baby out thereafter. Not impossible, but really difficult. We now know that if a cuddle's not allowed before the neonatal unit admission, for many babies, it's invariably weeks before they get a first cuddle from the parents. And that's a really difficult time for parents if they've not had a chance to hold the baby until many days and often many weeks have passed. that initial cuddle is especially important for the most preterm babies, the extremely preterm babies, because obviously they're at the highest risk of dying. And we don't always know from the word go which babies are destined to die and not make it to get home. So it's really important for them that they get that opportunity, and for their parents as well. And it's a real tragedy, and we've seen this in our own practice, that parents are sometimes only offered the chance to cuddle a baby when the baby's dying and they're being cuddled in, they're being called in suddenly, and only then is it offered. And it's a really difficult time for the parents to be offered it for the first time then. So it's a real disaster if the baby dies suddenly, never cuddled. And some parents are too distraught to want to cuddle a baby in those moments. And that could cause them a lot of grief later on and guilt. So is it common at the moment? There's very little in the literature up until recently to show how common or uncommon the practice of delivering cuddles is. So I'm going to present two papers that were published in the last couple of years. The first one in Acta Pediatrica and the second one in BMJ Open. So this first one here is a study from Sweden, which was done in the period 2008 to 2010. This was a survey of the parents of 81 babies who were born between 28 and 33 weeks gestation. Although they were more mature, most of them, the median age of the premature baby was 32 weeks gestation at birth. And this study was looking at the timing of important first events in the life of that baby and for the parents. And one of the questions they asked was, when did you first get to hold your baby? And only about 30% of mothers and fathers reported being able to hold their baby in arms in the delivery room or operating theatre. As part of the discussion of the paper, the authors of the paper wrote, one explanation for this may be that some infants needed immediate intensive care treatment. However, it's also possible that staff followed the conventional guidelines and routines for the medical and nursing care of the initial care of the baby, and didn't consider the importance of that early first contact between parents and the infants, even where it may have been possible. So the second study, looking at frequency of delivery and cuddle, this was a survey done in the UK in 3 tertiary level neonatal units back in 2011. It was published in 2013 in BMJ Open, so it's an open access article freely available. This survey asked 32 mothers of babies who'd been born between 24 and 32 weeks gestation. Again, the mean was older, more mature babies, so 29 weeks gestation. One of the things they asked them was when you first got to hold or touch your baby. None of the parents in this study, so none of the 32 mothers said they had the chance to hold or touch their baby until the time that the baby was in the neonatal unit. And for many of these parents, especially the more preterm ones, they reported it was often many weeks after the baby's birth before they first got the opportunity to hold them. And some of the comments reported in this paper in response to that, some of the parents' quotes here, I just wanted to pick him up and hold him, but I couldn't. He was on the ventilators and we just couldn't hold him for quite some time. And because of him being on the ventilator and with all those tubes hanging out of him, that was really heart-wrenching that he was going to be taken straight away, be born and taken away. I knew it was for his own good, but I still hated it. So that was comment from one parent. It doesn't have to be like that. Another parent said, you've waited so long, so yeah, holding them was amazing. Another parent said, it's such a big thing for the babies and for the mums to hold them. Another parent commented in response to the time she eventually got to hold the baby, now in the neonatal unit, it took about half an hour to get him out because of the wires, but no, it was nice. So the conclusion to how common the practice is unclear due to the lack of data published, but it does seem to be pretty uncommon still presently, as Emma's alluded to in her opening video there. Indeed, it was unreported in the literature for extremely preterm babies up until a couple of years ago. It's been my own personal practice for probably around 2 decades now. I don't know exactly when or where I started practicing it. But I remember it seemed a bit odd that we would be giving pre-viable babies back to the parents for them to die, or babies were unable to resuscitate back to the parents in the delivery room for them to cuddle, but we weren't given that opportunity for live babies. But it's been my routine practice for a couple of decades now, and it's good to see with more awareness and more parental involvement is becoming practiced in a handful of UK centres now, and there's growing interest, I'm pleased to say. What we can say and observe is that it's been unanimously supported by neonatal nurses and midwives. And they think it's wonderful to see and a wonderful thing for parents to have. So I think some of the reasons it's not routine practice still, well, we've never done it traditionally. The immediate admission of these small babies to the neonatal unit is being considered the imperative. We've always felt this obligation to rush the babies to the unit and get them underway in intensive care and in their incubators. But we just need to pause and think about that. We've been giving intensive care in the delivery room. We've stabilised the baby, we resuscitate the baby. Baby's in a beautiful state for that transfer to the unit. So that is the time we need to be thinking about, actually, we don't need to rush the baby around. Let's spend a few moments for that baby to have a cuddle from its mum and from the mum to cuddle the baby. So there's been lack of literature until very recently, and I think that's another reason it's not been routine practice. We've had no published guidance at all until recently, and Paul will present some of the lovely guidance that he's prepared as co-joint author of, joint first author of our paper. He'll present that a bit later in this talk. And I think rightly, there are concerns from colleagues about safety. Is it safe to do this? Gosh, that sounds ridiculous, that you putting the baby on the mother, should be around on the neonatal unit. So I think there's a genuine concern from colleagues that we can address and hopefully can address and show that it is safe to do. There's been a lack of supportive safety and outcome data, and I think that's part of the problem, but that's changing. So we've got some retrospective data now, which I'll present shortly, but there's also prospective collected data as well, which is starting to show that this practice is indeed safe and can be safely done. I think a really important aspect is that we've not listened to parents and asked them what they want and need. So once we do that, we start to see how vocal parents are in saying that this is a really important thing from their perspective. Again, very little literature, and there's been very few trials. So I can only find so far 2 randomized controlled trials in the literature, and these are those. So the first RCT published looking at routine skin-to-skin contact for preterm infants. So this was a true skin-to-skin contact trial in premature babies. So this study came from Katrin Mailer and Angela Kribbs in Cologne in Germany. And they randomized 88 babies in total, and they randomized to 2 groups to either get 60 minutes of delivery room skin-to-skin contact with the mother once the baby had been stabilized, or else the other group was that they could only have 5 minutes of visual contact with the baby with no holding or kissing and very minimal touch. So those were the 2 groups they randomized to. So quite a brave study. The babies were actually randomized at about 45 minutes postnatal, and that followed the baby's stabilization, including IV access and institution of an IV glucose drip. So really intensive care, or more advanced intensive care, was well underway here. All these babies have been stabilized with CPAP, which was their routine for their premature babies, and most of the babies had needed less invasive surfactant administration, or LISA as we call it, maybe also known to others as MIST, minimally invasive surfactant administration. Now, one thing this trial excluded was babies who were intubated and those who were needing more than 40% oxygen on the CPAP. So that's an important group of babies that were needing intensive care, but they excluded. The primary outcome for this study that was chosen was a really interesting one. They looked at bonding between mother and baby when measured at 6 months corrected age. So these were all babies who'd survived to go home, and they brought the babies and mothers back at 6 months, and they took a 4-minute video at which they were assessing the mother and infant responses. All these videos were reviewed by a blinded reviewer, and what they found was that the responses in the babies who'd had the 60 minutes of skin-to-skin contact with the mother, the relationships, the bonding between those mother and infants was better than those who had just limited visual contact only. And that reached statistical significance. They also looked at some short-term safety outcomes such as admission temperatures, and really there was admission temperatures were actually found to be higher in the babies who'd received skin-to-skin contact, and that was by 0.5 of the degree, and that was highly significantly different. So the babies were actually warmer on admission if they'd had the skin-to-skin contact with the mothers. They found no other differences in neonatal courses or short-term outcomes. So the second RCT that we found published, this was published in Acta Pediatrica, firstly published in November 2019 and then published in the print edition just a few months ago, in April, I think it was, 2020. So very recent literature. So this was a study from Stockholm in Sweden. This looked at 55 babies who were born between 28 weeks and 33 weeks and 6 days gestation. Now, these babies were randomized after birth to either immediate stabilization on the maternal chest following birth with skin-to-skin contact for the first hour, or else they were immediately stabilized on the resuscitator and then transferred to an incubator or cot. So essentially no maternal contact. And they looked at the short-term safety outcomes, but also the later outcomes of respiratory support and breastfeeding rates. Now, they did find a difference in temperatures. It's very small. It was only 0.3 of a degree centigrade, but it was significant. They found that the babies who'd had the skin-to-skin here were marginally cooler at 1 hour of age. Probably not a clinically significant difference, but nevertheless, it was statistically significant. But they didn't find any differences between the groups for respiratory support needs or breastfeeding rates. But as I say, it was quite a small study, only 55 babies. Obviously, it wasn't powered to look at breastfeeding or bonding rates. So small literature, emerging literature, though, and definitely the genuine concern from colleagues, is it safe to do this? So I went back and looked at our own practice. I've been a consultant in Norwich for 16 years now. So we went back and looked at all the babies that have been offered delivery and Cuddle who were born extremely preterm. And I wanted to look at some of the short-term safety outcomes here. So the question was, does offering delivery and Cuddles to mothers of extremely preterm infants significantly delay the baby's admission time to the neonatal unit, or does it affect their admission temperature? So this was done as a retrospective case control study. So I looked at all the babies I could identify definitely had a delivery and Cuddle who were born at less than 27 weeks gestation. We wanted to match them as best we could for babies who hadn't had a Cuddle, but who'd only been shown to the parents. So this was done by looking at the neonatal documentation, and I reviewed about 400 neonatal discharge summaries of babies who were born in a 12-year period, 2006 to 2017, to identify those who'd had a Cuddle compared with those who'd just been shown to the parents. They were matched for gestation, gender, delivery mode, and multiplicity. We looked at admission times and temperatures, but also survival to discharge. Altogether, there was just under 400 babies admitted to our unit in that 12-year period of below 27 weeks gestation. We looked at the inborn ones only because they were the only ones likely to have had a delivery and Cuddle, not the outborn ones, because it wasn't common practice elsewhere. What I found was I could identify 27 out of the 233, so that's 12% who definitely had a delivery and Cuddle prior to the baby's neonatal unit admission. Probably quite an underestimate because I relied on the documentation at the time to say that they'd had a Cuddle with the parents before being admitted. Now, all but one of the babies in our series was intubated at the time of the Cuddle. So unlike that RCT I've just presented to you before, these were all babies of any gestations, irrespective of whether they would need an intubation or not. Now, in that era, as I say, up till about 2017, it was pretty much routine that the most extreme preterm babies would be intubated, get the surfactant, and then be admitted. Nowadays, in more recent years, that's not our practice, and we've moved towards not immediately intubating and stabilising them if possible on non-invasive ventilation. So more of the Cuddles these days are done on non-invasive ventilation. So altogether, I was able to get the data for 27 of the babies, all of them, and we were able to match them with 27 babies where the documentation indicated they'd been shown only to the parents before admission. And here are the results. So they were very well matched. You can see that the median gestations here between those that were Cuddled and those that were shown only were very similar. So median 24 weeks gestation. What you might observe is how premature some of the babies that were getting the Cuddle were. So right down to 22 weeks gestation here, we didn't have any cut-off for gestation as to which babies would or wouldn't be allowed to be Cuddled. So there's no significant difference in gestational age. There's no significant difference in median birth weights either. So the outcomes we were interested in were the short-term outcomes of admission times to our neonatal unit. So our neonatal unit's only about 1 minute away from the delivery room labour ward. And what you can see is there was no significant difference here between the median admission times. It's obviously quite a range, so some babies were admitted very quickly. So even those that were cuddled, some of them were only getting a brief cuddle for a couple of minutes before admission. Others were getting a longer cuddle, and it may have been up to 41 minutes before some of the babies were admitted. There was no significant difference between the groups. Importantly, we didn't see any significant difference in temperatures on admission. You can see that some of the lower range of temperatures weren't particularly admirable. We've improved on that in more recent years by various measures, some of which Dr. Corley may touch on. Survival to discharge, there was no difference. So these were retrospective data. We're published them as part of our article, which you can download from the shared resources with this webinar. Retrospective data, limited in that respect, but nevertheless some reassuring safety data. And I think over the next couple of years, we'll see more and more papers publishing prospective data showing the safety of delivering cuddles. So my conclusion from this retrospective review was that offering parents a brief delivery and cuddle of their extremely preterm baby prior to the neonatal unit admission, it did not significantly delay the baby's admission, nor did it adversely affect the neonatal admission temperature. So which babies should we be allowing or facilitating a cuddle with their parents on their birthday? My answer to that is most babies. In fact, the vast majority of premature babies, we should be thinking about it and trying to offer it to the parents. And this goes, in our experience now and practice now, for any birth gestation. The vast majority of babies are or should be eligible to have a delivery room cuddle. There are certain babies where it's probably not indicated, or maybe more difficult, or maybe truly contraindicated. So a few words about those. Obviously, if the mother's had the general anaesthetic and the baby's being born by cesarean section, then it's going to be impossible in that situation. But don't forget fathers. Often the father's present alongside the mum in the delivery theatre, and he may well want to have a cuddle for a few minutes. We can think about the fathers, and we should always think about the fathers in that situation. If the mother's acutely well and needing medical stabilisation herself, obviously her needs must come first, and it'd be completely inappropriate to take the baby back over to her even when we've stabilised the baby if she's getting urgent medical attention following the delivery. If the baby's born with known or unknown and suspected from delivery difficult airway or congenital airway malformation, then it may be potentially dangerous to offer the cuddle in that circumstance when there's any doubt about the airway. Similarly, there may be some babies who are needing ongoing prolonged resuscitation that can only really be efficiently delivered in the neonatal unit. So babies who need an ongoing volume or blood products or inotropes, it's not going to be appropriate for them to be taken back to their mothers. They're sort of still in that stabilisation period, so they're not considered stable enough for delivering cuddle. I think more debatable cases are babies who are known to have congenital cyanotic heart disease, or maybe unknown and just presenting with suspected cyanosis postnatally, not pinking up. Those babies, there may be more urgency to get to the neonatal unit and start some prostaglandin infusion, obviously, but possibly a few minutes. In our own practice, there have been babies where this has been offered and really appreciated by the parents. So obviously, once the babies are taken around to the unit and plugged into prostin and infusions and sometimes endotracheal tubes, it becomes really difficult for the parents to hold the baby. And before long, the baby may be taken away to the regional centre, and it may be again weeks before those parents have had the chance to cuddle the baby. Again, debatable is the babies who are born encephalopathic and requiring active cooling to protect the brain. But then again, these are babies at high risk of mortality, morbidity. We're pretty good at cooling babies in the delivery room, even inadvertently. So logically, a few minutes in the mum's arms is really not going to harm that baby. I think more challenging situations, but definitely not contraindications, are where the baby's been born or delivered by awake cesarean section. We've been able to facilitate delivering cuddles in that situation with the full agreement of the anaesthetist, the obstetrician, the midwives who are in the room as well. And again, multiples, I'll give you some examples of babies where we've facilitated delivery and cuddles for twins and even triplets. So that is more challenging, but not impossible. So I'd like now to move on to what parents think and give you some of the feedback we've had from asking parents what your thoughts on and experiences on having had delivery room cuddle of your baby. So we did it was a survey, retrospective survey, looking back and asking mothers of the babies, many of the babies who'd known to have had a delivery and cuddle. Again, we focused on the extremely preterm babies and asked them what they thought. Altogether, we were able to identify about 30 mothers altogether, but 32 mothers altogether. 10 were excluded. 9 of these were bereaved, and we didn't want to approach those bereaved mothers out of the blue. I think that would have needed ethics approval. There was also one poor mother who herself had died. She'd given birth to a 25-week gestation baby and had died of choriocarcinoma some 3 months after delivery. So we didn't approach the father in that family. Again, we felt that was appropriate. So all the mums we did write to with the questionnaire were mothers of still living babies. So we wrote to all 22, and out of the 22, just over half of them replied. So remember that this was going back right over a 12-year period. So for some of these mums, it was a long, long time ago when they would have had that delivery and cuddle. And we were writing out of the blue, really, to ask them, could they remember it and what they thought. So here are some of the questions we asked in this survey. So first of all, we asked, can you actually remember being given your newborn baby to cuddle in arms in the delivery room before he or she was taken to the neonatal unit? And these were the responses they could choose. And out of the 10 that responded to that question, all 10 of them said that they could vividly remember it. And at the time that they wrote back to us and answered these questions, their babies were actually up to 12 years of age with a median of 5 years. So this was a long time in the past for some of them, but they remembered it very vividly. We asked, how important was that first cuddle to you as the mother of a very premature baby? We asked them to rate this on a Likert scale from 0 for not at all important, right up to 10, extremely important. And these were the responses we got to those mums who replied to us. So you can see the vast majority of parents there rated that first cuddle as being extremely important for them. There was one mum who didn't rate it so, and I think this is a mum who hadn't been well prepared as to what to expect for the delivery and cuddle. And it was all a bit of a shock to her when the her baby was brought over to her. She wasn't expecting it, she hadn't been briefed about it. And it was a good example to show that if we're going to do it, we need to do it properly and counsel the parents properly. We asked the parents what were their feelings at the time of that very first cuddle that they had in the delivery room. And some of the responses that they were able to give were they initially scared or were they relieved? What were their feelings? And these were the typical responses we got back. So 3 of the mums felt scared at the prospect of holding the tiny baby. 6 of them felt relief and reassurance when they were given the baby to cuddle for the first time. 6 of them had intense feelings of pride and love. And 2 of them made some other comments. So one said, I was grateful but stressed. And then this was the mum who in the previous slide had put down 4 for importance to her. Another said, I was keen to hand the twins over to the doctor and nurses as I was nervous and worried that they could not breathe very well without a ventilator. So again, this all is really good feedback because it shows us how we should not do a delivery and cuddle. We've got to prepare those parents that actually we're doing the breathing for your baby, we're being the ventilator, we're providing that intensive care while your baby is with you. This is a really crucial thing we need to remember. The intensive care is ongoing when it's with the mother, back with the mother. So we also asked how important, so this is a general question, how important do you as a parent of an extremely preterm newborn baby, how important do you think it is that other neonatal units, neonatal doctors and nurses should try and offer as far as possible mothers of newborn premature babies an initial cuddle before the baby's taken away? So we asked them to rate it, and again, the vast majority who responded said it was extremely important as a concept that doctors and nurses should be trying to facilitate it for mothers of other premature babies. We also gave some open-ended opportunity to respond. We asked, was there anything else the doctors or nurses did which helped or reassured you in the delivery room during the cuddle? So these were some of the quotes we got from parents. So this was one from Josie, mother of 23-week gestation girls, and there's a picture of her there with her 23-week twin in arm being ventilated, and she's able to cuddle a baby before we've taken to the neonatal unit. So she said, they said to me, here are your daughters, give them kisses. Said they were doing handheld breathing for them while I had my cuddles before they went to the neonatal unit. Some other parents responded with these quotes. So it gives you an insight into what the conversations are between the nurses and the doctors while the cuddle's happening. So presumably one of the nurses had said how handsome her son was and how I seemed to look comfortable. So this mum said that really helped her despite the chaos in the room. Another mum of 26-week twin boys said they were telling us and reassuring us that they were fine and breathing, and it was normal for a baby that size not to cry. And then one mum said making that initial cuddle as close as it could have been to had he gone to full term to make it feel normal was really great. We've had that from other mums as well who've had the cuddle, and they say it's, you know, it's, and those who haven't had it, they say it's something they've been deprived of, that cuddle that they would have got had the baby gone to full term. So we also asked, could anything have been done differently with the delivery and cuddle that could have improved your experience? So one mum said, oh, it would have been nice to hold them longer because I didn't get to hold them again until a week later, but I understood why they needed to be taken away. Then a mum of a 24-week gestation girl said, oh, it was all very quick, but I just wanted medical attention for her. Looking back, I'm glad I got the cuddle in case I lost her, but I just wanted them to help her. That was more important to me. For me, I was very stressed with the cuddle, and in hindsight, I'm glad I held her briefly while wrapped in a towel, but I've often wondered why on earth was I allowed that when she needed so much medical attention? And it makes me panic to think I took any time away from all the serious medical help she needed. But if I'd lost her, I'm happy that I'd had that cuddle. So again, this is the mum who we feel hadn't been properly briefed and counselled leading up to the delivery and cuddle. And this feedback's really helped us to ensure that we prepare parents properly before we bring their baby back to them, make sure they want it, we offer it, make sure they want it, and make sure they know what to expect. So some of the comments, one mum of a 26-week gestation boy said, it was incredibly important to get that cuddle as I didn't get to hold my son again for 2 weeks as he was too sick. That cuddle helped to initiate my breast milk, and I was able to express and eventually breastfeed my son when he was stronger. So some nice quotes here from mum of 23-week twin girls. So this is a picture of them at about a year of age from the local paper, reprinted with permission from her. So this mum said, I got a cuddle with both my daughters. It was so beneficial to hear them cry at birth and stop to have that first cuddle was what we needed, as I knew I wasn't going to have another cuddle for a while. And to have that first cuddle, I felt like a mummy. And I was very thankful because I didn't get another cuddle with them until 24 days later, I think it was, which again was very emotional to see them and touch them. And maybe it was that first touch was what we all needed, knowing it was going to be a really tough journey ahead. Thankfully, we are the lucky ones. Didn't think that at the time, but maybe that was what helped them survive. So that's the background, the concept of why I believe we all need to think about doing this for the baby's sake, but for the parent's sake as well. And I'm going to hand over now to my colleague, Paul Corley, who's going to present on the practicalities of the delivery and cuddle and take you through the safety issues and how you might think about practicing it.
Thank you, Paul. Can you hear me?
How do I hand over? Let me just stop sharing. Right. Thank you.
Thank you. Can you see my screen and can you hear my voice?
Yes, we can, Paul.
Great. Okay, thank you. Yeah, so thank you. Yeah, I'm going to cover the practicalities, consider in a bit more detail some of the risks of potentially doing a delivery room cuddle. And like Professor Clark, I've got no conflicts of interest to disclose and no connections with Dräger. For my session, as I said, we're going to look at the ABC practicalities of giving a premature newborn their first cuddle. And by ABC, I hope you'll appreciate that it's simple, easy, and straightforward. I'll start by talking a little bit about my experience and motivation for doing this. I think that's important, and I think there'll be many shared reasons between us for wanting to do this. I'll then look at some of the potential risks relating to the delivery room cuddle, and then practically how these can be controlled, managed, and I think hopefully it'll become clear that by controlling these risks, actually you can maintain high evidence-based standards and really actually improve early newborn care. And I think relevant now is considerations to the SARS-CoV-2 pandemic. So I'll look at some of the evidence relating to newborns and COVID-2. My first introduction through this really was through Professor Clark. I was very fortunate enough to be working with him at the unit, and also fortunate enough to come across Charlie and Jack's story, which you very movingly heard about at the start of this presentation in that video. It was published as a case report in Acta Pediatrica, and I'd recommend you all go read it. And after doing that, I was personally motivated to give every baby in my care a delivery room cuddle whenever it was safe to do so. And I'd say that it naturally feels right. And in the rare circumstances where it's not been possible within the delivery room, it certainly feels now uncomfortable to me and not right. And there's a link there at the bottom for the case report. I guess what also motivates me, more with my neonatology hat on, is that I'm very keen on the importance of good neonatal neurological care, and there is a wide body spanning decades supporting the use of skin-to-skin and kangaroo care, and I see cuddling of newborn babies not as a new practice. Even back in '91, we can have a study here which showed that it was very safe and stable for babies very small to be cuddled. This was back in '91, had physiological stability, good temperature management, improved patterns of breathing, oxygenation, heart rate. More recently, we know we've seen meta-analysis, and in an all-resource setting, we know that kangaroo care shows to reduce neonatal sepsis, improves exclusive breastfeeding, and improves pain measures, head growth, oxygen saturations. And I'll let you interpret the forest plot there for mortality risk, with the right side being those who don't receive kangaroo care and the left side those that do. I mean, this is a really good paper. I love it. It's from Columbia, the 20-year follow-up of an RCT looking at kangaroo care versus traditional care, which was babies not receiving cuddles. And those who receive cuddles have reduced hyperactivity, reduced aggressiveness, reduced socio-defiant conduct. They have reduced school absenteeism, and even when they're older and grown up, they earn a higher wage. So there's really benefits to society between this effect of parents cuddling babies. And if we think about this more scientifically, even, there's evidence that those infants receiving skin-to-skin care have enhanced sleep-wake cycling, and there's electroencephalographic evidence of improved and accelerated brain maturation from several papers. And as we heard from Professor Clark, the European Foundation for the Care of Newborn Infants really highlights this as particularly important for very preterm infants, and really feel it should be started as soon as possible as standard care. And likewise, it is a research priority. We can see this paper from the Lancet, which was highlighting newborn health research priorities globally and addressing barriers to kangaroo care. Cuddling of infants was within the top 10 newborn health priorities. So let's have a little think about how to practice safe delivery and cuddle. And I think in doing so, there are several contributing factors. It of course depends on what equipment we have available to us, what population of newborns, how premature, what other comorbidities they may be born with. We need to consider the delivery room setup, which will be different between theatres and non-theatre environments. And then also to a certain extent, the distance between our delivery suite and the neonatal unit may impact on how much we can devote to deliver and cuddle. But before we think about the equipment and the technicalities, I think it's good to just consider the risks for a moment and then how we can control them. I have to say that I think the biggest risk to newborn infants relating to deliver and cuddle is more related to human factors than the physiological ones. It's important that we acknowledge the role of our environment, our organisation, and ourselves as individuals and the risk of human error. And when practicing a deliver and cuddle, as in anything we practice in medicine, having situational awareness of what we're going to do, good communication between the team, which is closed looped, a nominated experienced leader who can direct the cuddle safely, and most importantly, all shared a mutual understanding of the process of the cuddle. It's when there's miscommunication and a team who is not used to doing this go to do different things in different timings when risk can occur. And I think this video, hopefully it's playing, is a really good example of where things could go wrong. If you're not communicating effectively, if you haven't got a dedicated leader, you haven't got a shared model, then things can easily go wrong. And it would be tragic if a neonatal team attending a preterm baby were to replicate this, really. But of course, there are factors intrinsic to the infant. We know that preterm babies have high surface to area volume ratios. They have absence of insulator subcutaneous tissue. They naturally have wet skin, and they have limited internal thermoregulating means for generating their own temperature and fighting cold stress. So that all means there is a risk of hypothermia in the delivery room. We know that preterm babies have surfactant deficiency, and their premature lung architecture also puts them at risk for respiratory insufficiency of prematurity, and we need to be mindful of their respiratory needs. And finally, we also know that they do have limited energy stores. Low glycogen stores may be used up through the stress of labour or delivery, and we need to identify that preterm babies are at risk of hypoglycemia in addition. So potential risks, really, to summarise: there's instability of the baby. If as a team we're not working, could we lead to dislodgement of their ventricular tube if they're intubated? Could we run out of oxygen if we haven't checked the oxygen cylinder? And then the baby itself, low temperature, low sugar, acidosis if we're delaying admission. But really, these are things which can be identified and then controlled. So efficient teamwork should prevent a NICU admission being delayed. And I think you'll get to hear, as you would have heard from Professor Clark as well, that crucially during a cuddle, intensive care is not neglected. It's ongoing, and this baby is assiduously supervised. So as we heard, this cuddle isn't right from delivery. It's once we're happy that the baby's been resuscitated or stabilized and is ready for a cuddle. The moment before, we would traditionally maybe merely show the baby to the mum or dad and then take them to NICU as the moment to give them the cuddle. And safety of all is paramount. Duration will be variable. Typically, we would practice maybe 5 to 10 minutes. Shorter durations may be a good starting point, but as long as you're monitoring this baby and giving ongoing intensive care, you should be replicating what you're doing on the NICU anyway. And this is kind of a flow diagram to think about all those aspects where we can control human factors and the physiological risks we see in preterm babies. It starts right from the antenatal stage, and you need to plan and prepare. Of course, the antenatal stage may be time limited. There may be rapid delivery of the baby, but team communication is vital. You need to establish early on the candidacy, for instance, for delayed cord clamping, and within the team, hopefully before the baby's born, establish that this baby may well be suitable for a delivery and cuddle, and make sure that the midwives, obstetricians, and anaesthetists may be on board and prepared. The delivery room itself, you need to make sure you've removed any unnecessary clutter, and you've got a layout for which you can move your equipment into a position where you can support the baby during the cuddle. And from a thermoregulatory point of view, if you can set the room temperature early and minimize drafts, then you're going to reduce your incidence of admission hypothermia. And then again, as part of this human factor role, we need to assign clear team roles for every member. I think talking through the equipment that you're going to use and a mental model of the process is also important, from stabilization to cuddle. Again, from birth and stabilization, it will be variable as to what equipment we may have, but certainly for those that are very low birth weight, very preterm, plastic bag with radiant heater is necessary to maintain their temperature. Use of a hat, making sure we're opening the airway, delayed cord clamping, all standard newborn stabilization techniques really. And I think the key here in that bottom bit is that you've got respiratory stabilization. So you have primary optimal respiratory support, be that invasive or non-invasive, and you're happy that you've got stability of the airway and a stable way of delivering whatever respiratory support that baby needs before doing the cuddle. And throughout this period, you're going to have continual assessment of the baby's vital signs, and you're going to act on them as required. So of course, equipment will vary. Essentially, I think it's useful to have a heat source, be that, well, primarily a radiant heater for resuscitation and stabilization. You need medical gases, you need a way of delivering those in a controlled pressure way, suction and lighting. And from a thermoregulation point of view, we're going to try to control all the means of which heat may be lost, so through radiation, convection, evaporation and conduction. And certainly in our practice, we'll do that with plastic bags or suits, use of hats, and sometimes babies may need use of heated transport mattresses as well. Again, this is all very standard. You're going to need stuff to control the baby's airway before the cuddle, and that may be initial resuscitation as a face mask with a laryngoscope as well. But if you're going to deliver non-invasive support, it may be you need your CPAP interface ready. Or if you're going to intubate the baby, you need a way to secure the tube. And in terms of monitoring, then any monitoring that you have on the neonatal unit, you should be able to replicate that within the delivery room environment. So ideally, you're going to have a monitor available with a means of measuring this baby's saturations. I think continuous temperature monitoring is vital to safeguard these babies' temperature. Where that's not practicable or the equipment isn't available, then regular temperature checks I think are important. And certainly it's very desirable if this baby is intubated to ensure that you've got some form of having early detection of tube dislodgement and the reassurance of having continuous and tidal CO2, which may be via capnography or by a colour change device. There's lots of different means of monitoring temperatures. Different equipment has is available depending on centres. So if we look at this flow chart now, we've stabilised the baby, we're happy that they're stable, we're happy with their temperature, and they've got a definitive means of non-invasive support. It's at this point you assess the suitability for cuddle. So there's some kind of ready reckoners, I guess, to ensure that this baby's stable, and they're all related to the fact that you can increase your respiratory support and oxygen if you need, the baby's warm, and that the airway is stable. I think it's important also to define early on if there's anything which may mean this baby can't have a cuddle, and these are some of the things that Professor Clark had explored as well. Essentially, I think don't move this baby if it's cold. If it's cold, we need to warm it up. Movement through the air is only going to make the baby colder. But as long as we've got stability, then we go for the cuddle. And our final things we're going to do is ensure that the team are ready. You have to bear in mind that an anaesthetist, obstetrician or midwife within the setting may actually have never seen a preterm baby being cuddled. So they too need to be prepared, and they will help once they're on board. And as we've heard as well, it's also very important to update the parent and ensure they are mentally prepared. And then there's an option here at this point to weigh the baby. The reason I put it here actually is that once you've got the weight, you can start prescribing and preparing their fluids and medications, which would lead to efficient teamwork, but that's an optional thing at this stage really. So for the parents, what I like to say is that I reassure them we're here throughout the cuddle, we're here to support them, reassure them that their baby is stable, they're receiving the optimum care they need, that they're on continuous monitoring and they're safe, that they're comfortable, and really they may benefit from this cuddle rather than worrying the other way around. And I think this is a great time to encourage videos and photos and videos of the precious moment, which will be important for their memories in the future. In our paper, we cover this flowchart. I think it's figure 3, and that's available to download. It covers the antenatal birth stabilization, suitability, and cuddle time phases. And likewise, figure 4 then thinks about the practicalities depending on what equipment you have available. So in centres which have a transport incubator with a transport ventilator, this would be my preferred means. What I would advocate is moving the baby into the incubator, setting up on your transport ventilator or non-invasive CPAP machine, and then bringing the incubator close to the mum and bringing the baby out for the cuddle. And you can see in this diagram that then the baby is continuing to receive the ventilation whilst being skin to skin, although maybe in a bag as well, hat covering the head, covered with a towel. And if available, then you may even have the option to humidify the medical gases at this stage. And some incubators, of course, have syringe drivers. So if you've secured IV access, you could deliver dextrose, and in more mature babies with congenital heart disease, I've also done this for delivering Proston within the delivery room, supporting their cuddle. Another option, of course, is to use the whichever device you're using to resuscitate the baby with. So a controlled pressure device, T-piece device, bringing the resuscitator near to the baby with the gas supply, and then delivering either manual intermittent positive pressure ventilation using the T-piece, or if you've got a face mask, holding that face mask over the baby's mouth, and either delivering PEEP if you've got a controlled pressure valve to manipulate or replicate a CPAP device. And here is a very special moment, an example of a baby receiving IPPV through an endotracheal tube using a T-piece device. And we can see here the option of using a face mask PEEP device to deliver continuous positive airway pressure CPAP to a baby during a cuddle, where the option for a nasal interface for delivering nasal CPAP wasn't available in the delivery room. So I hope that shows that during a cuddle, they're going to have ongoing intensive care. They're going to have continuous optimal respiratory support, whichever is best for that baby. And it may be that they've required surfactant beforehand, but they've got ongoing intensive care monitoring. We're going to keep them warm. We're going to keep an eye on their temperature and act if we need to. And so in doing so, by having ongoing attention to their thermoregulation, by having ongoing provision of respiratory support and effective monitoring, we are in fact enhancing the baby's care, and these are all measures of good practice. A few other things. So I think efficiency is key, and there are things that you can do whilst you're monitoring this baby. It's probably at this point at delivery, this baby is going to have the most medical professionals around it in its life than when it's on the neonatal unit. So I think during the cuddle, you can be prescribing any necessary medications and infusions. You can call down to your neonatal unit to let them know the baby's delivered and that you'll be en route soon. And of course, the general things that babies are going to need are the vitamin K, caffeine, antibiotics, infusions. These can all be prepared. If you're looking to implement this on a unit, I think it's important to try and get a guideline together. Training and simulation prior to doing it on a real case is very useful. You can practice it big and small. Perhaps starting with bigger babies and then going down to the more preterm babies will enhance your practice and improve your confidence in doing it. And it's important to have everyone involved so everyone knows what's going on during the cuddle. And local champions are key, medical and nursing leads. They can disseminate knowledge, troubleshoot, and also importantly stoke enthusiasm. And of course, whenever we're changing our practice, even if it's looking to improve it, it's important to have appropriate order and governance to make sure we're effectively delivering this. This is an example of one of the units in the UK giving simulation training. So this is a dummy, and they're simulating in their unit a baby receiving a delivery room cuddle. And this unit then went on to do a series of very preterm baby cuddles, which they've published. We're really delighted to see that and see their enthusiasm and success. And I'll conclude here about the cuddles then that wherever possible, all parents of all preterm babies should be given the opportunity for a deliver and cuddle following initial stabilization. It's irreplaceable, that safety is first, and there is ongoing intensive care. We shouldn't significantly delay NICU admission. We saw from the numbers that Professor Clark showed that actually the median was slightly quicker for babies that received the cuddle. Good teamwork and good communication are essential. And really, this is the essence of family-centered care right from birth. So that's really what I wanted to say about safety and risk factors and the practicalities of doing a cuddle. It's obviously a whistle-stop tour. There's a confounder now with SARS-CoV, so I think it's just good just to have a quick look at the data regarding the risk of SARS-CoV-2 to newborn infants. So we know in some countries, many countries even, that babies are being separated from their mum, and this is likely to have a negative effect on feeding and bonding, and certainly would prevent a cuddle. But that overall evidence to date shows that the risk of perinatal transmission of the SARS-CoV-2 virus is low. There's emerging evidence in the literature showing that restrictions between baby and mum because of COVID are having a real detrimental effect. We've got this multi-centre survey from last year which shows that restrictions relating to coronavirus are having a negative impact on all the family, with reduced visiting and of course then impaired bonding in nearly half of families, including impact on breastfeeding. The risks of the newborn, what do we know? Well, there's this population study from the UK, which I'll share from you, looking quite early on in the pandemic, but in babies in their first 28 days of life. They identified 66 cases of inpatient neonatal SARS-CoV within the UK, which they gave an instance of 5.6 per 10,000 live births, so it isn't common, but it can happen. Interestingly, of the newborns that suffered from coronavirus, 42% were defined as having severe neonatal SARS-CoV. But actually, if you take that in the light of what their criteria for severe neonatal SARS-CoV was, some of them are probably not what we'd expect. So if they have an abnormal chest X-ray, a raised CRP, a low white cell count, or have apnea, cough, or a temperature above 37.5, then they were considered severe. There was one death, but it was unrelated. And 5% of that population of neonatal SARS-CoV needed ventilation, so not a lot. 15% needed non-invasive ventilation. And actually, if you think 24% of them were preterm babies, that's probably not surprising. And I think an important thing to highlight is that nosocomial infection was acquired as well. So just if we take a baby away from its mother doesn't mean that we're not going to give the baby SARS-CoV-2 via other means. Good, and then this is just a graph showing some of the symptoms and signs that the babies may have presented with. The majority having either hypothermia, but a significant proportion, nearly half, having some degree of respiratory distress. There's also good data from America. This is ongoing actually. They're updating this regularly from their registry of CoV. So of infants tested, they've had 3,850 cases, and you can see that the majority were born vaginally. And in terms of resuscitation, the numbers needing oxygen, PPV, or intubation, if you're considering over 4,000 cases, really is not more than the general population. And we can see the flip side, the maximal respiratory support these babies are needing, only a very small proportion were needing ventilation or oxygen or non-invasive support. There's also data from pediatric studies, and we can focus in on the younger cases from these. So of pediatric cases that needed admission from SARS-CoV, 15% of those less than 1 month needed ICU admission. And this violin plot shows on the y-axis age, and then no ICU admission and ICU admission. You can see actually broadly there is a widening in younger infants. So younger infants probably are at slightly more risk than older ones of SARS-CoV infection. And again, just replicating this in England, we can see that of those born preterm, they're at higher risk of ICU admission if they develop SARS-CoV-2. So really, I want to highlight that neonates can be infected by SARS-CoV-2, but it's not common, and the majority of babies do not become significantly unwell. And if they are, then there's a very, very low attributable mortality. So I think really evidence shows us that the risk of perinatal transmission is low. And in light of this, I think if you've got an asymptomatic parent that's not known to have SARS-CoV, and definitely if they're confirmed SARS-CoV-2 negative prior to the delivery, then there should be no interference of this delivery room cuddle, as long as everyone's adhering to appropriate personal protective equipment. That said, we know that preterm babies seem to be at higher risk from transmission and becoming more unwell if they're infected. So if you have a parent who is symptomatic or confirmed to have SARS-CoV, then at present it would seem sensible not to practice delivery room cuddle, just because of the proximity this baby is going to be to its mother's airways. And I'll end there just with a slide of our paper, which you can download from the handouts. It's also freely available online as open access. Delivery room cuddles for extremely preterm babies and parents, concept, practice, safety, and parental feedback. And with that, I'll just hand back over to Professor Clark for a final summary, and we can see a video now of a delivery room cuddle in action. Thank you very much.
Okay, so we've seen the practicalities of how to practice. And I said earlier, we don't place any gestational age limit on which babies we will offer it to. So whichever babies are considered eligible and viable for admission to our neonatal unit, we will count them in and think about whether we can offer their parents a chance of a cuddle. So I'm just going to show an example here of a little video clip of a 22-week gestation baby who was born in the last couple of years. And this is shared with the kind permission of this baby's parents, one of whom is Sheila Atuono, who's one of the co-authors with us on our Acta Pediatrica paper. So I want to tell you, before we see the video, I'll just go through the sequence of events surrounding this little baby's delivery. So this is 22 weeks and 6 days gestation baby, born in July 2018. Luckily I was on call. It was one of the nicest deliveries I've ever been at, and this is the sequence of events here. So we had the opportunity to meet parents very briefly before the delivery and go through the sequence of events that would ensue and prepare and say, you know, once baby was stabilized, we'd be able to bring the baby for that cuddle. Baby actually came out in really good condition, was attempting to cry on his delivery. We practiced a minute of delayed cord clamping, and then he was moved to the resuscitator. He was already showing spontaneous respirations by 2 minutes. We did an elective intubation at 4 minutes and confirmed good air entry. By 5 minutes, the saturations were still low in air, so we gradually increased the oxygen delivery to the baby, needing a PIP of 20, and we were doing this by hand ventilation via the T-piece and endotracheal tube. Within 5 minutes, the heart rate was confirmed to be above 120 per minute. We gave poractant alpha surfactant, which is a porcine-derived surfactant, at 12 minutes. Not infrequently, tubes dislodge, and this was no different case here. This tube dislodged by 15 minutes, and so we had to replace it and refix it. So that delayed the process by about 10 minutes before the baby had been reintubated and the tube was secured. But by 26 minutes, all was nice and stable, and that was the moment where we'd normally be taking the baby to the neonatal unit. But this is the moment where in our unit now we routinely practice the delivery room cuddle. So this is the point where the baby was moved still on the resuscitator alongside the mother's bed, so that we could then give her baby to cuddle. The baby was then transferred into her arms, and here she then had an unhurried cuddle, and it lasted 9 minutes altogether. All the while, ourselves, the nurses and doctors who were there, were doing the ongoing ventilation for this little baby. So again, it's thanks to Sheila that we're able to, and her partner, that we're able to share this little clip that was taken on father's mobile phone and shared and indeed published with their permission. So this video clip actually is published as a supplementary video file to our Acta Pediatric article. And if you go to the Acta Pediatric site and search for our article, you'll find it under the supplementary materials, so you can download it yourself. So if I could just hand over to Katya, please, to play that video clip.
Go put him back in. He's absolutely fine if you want another couple of minutes. He's absolutely lovely. He's doing a bit too well, which is why I just asked Sam to turn him down a little bit.
So it's actually there. Pull in a little. That's it.
Okay. Just now keep it on your
Okay.
Just release your hand.
So what we've got saturations 95.
Heart rate's 170.
Fantastic.
His temperature is perfect.
Super.
You've grown him very well, Mummy.
Thank you so much. Thank you, everybody. Thank
Very good job there. He would have been huge if you'd gone all the way.
So it's early days. So what we'll do when we get round, we need to put some special lines in into his tummy button, so we can give him some sugar solution and then some liquid feed as well.
Okay.
And then really important will be, are you planning to breastfeed? Have you thought about that?
Yeah.
That'll be really crucial. If you can get work on, overnight, get some milk expressing, and then we can trickle that down into his tummy.
Okay.
We'll be doing an X-ray to check the position of the lines.
Okay.
And then just see how we go, minute to minute, hour to hour, and so far so good. We couldn't have hoped for a better state of him to start with. He's super. And good weight as well. We'll weigh him when we get round.
Yeah, do you know?
We don't know his weight yet.
Okay.
But as soon as we get round, we'll be able to weigh him and then let you know what it is.
Daddy, did you want to stay with Mummy, or did you want to come across with us?
I stay with
Yeah, let's
go. Yeah. You're gonna be fine?
We'll be doing lines and bits, but you can all sit with him and
Okay.
we can keep you updated.
You talk to him.
Okay.
To talk to him.
Telling you bad jokes.
See, Mum's not lost his sense of humour.
Oh my god, yeah, bad dad jokes.
It's just part of being a dad. Welcome to the join that club now. Bad dad
Finally,
jokes.
I have an excuse.
Dad dancing.
There you see, that was July 2018, one of the nicest deliveries that I've ever been at. Apart from my own children, I have to say that, but no, it was really nice, and I hope it gives you a sense of how calm it was in the room. There was no rush, no urgency. Everything, the baby had already been stabilised, and this is a lovely moment where we could just step back and enjoy those very precious moments right at the heart of the family, and hopefully reassure them what's going on, what we're going to do. And it's such a nice time that the mum and dad can meet the baby for the first time ex utero. So just to follow on from what happened with little Nicodeme. So by the time 9 minutes of cuddling with mum, and then dad had a quick cuddle for a few minutes. We carried on the hand ventilation all that time. So it's about 40 minutes before we departed the delivery room with the baby in the transport incubator now. Neonatal unit admission was a minute later, still ventilated, but he was already not needing any supplementary oxygen by this time. And you can see his admission observations here. So temperature 36 degrees, glucose first measured at 55 minutes postnatal was 3.1 millimoles per litre, and there was no sign of any acidosis at all. So he arrived in a lovely condition on our neonatal unit, and both he and his mum and dad had the benefit of having cuddled him. So Sheila actually told us that the very next time she got to cuddle him wasn't for about 5 weeks later. So if we'd not offered that cuddle, it would have been many, many weeks before she'd have the first chance to hold her baby. So this little lad was born in Norwich. Norwich is about 2 hours away from London. The family had been up visiting the region when he was delivered. So he spent the first 3 or 4 weeks in our unit before he was transferred to one of the London units much closer to home. And I happened to be visiting that London unit that he went to in November of 2018. And it was around the time of World Prematurity Day, and the wall in the unit was covered in all these posters where the parents had written some comments about what prematurity meant to them. And I just happened to see this one written by Nicodeme's mum on the wall. So she described prematurity as the storm before the calm. I like to think of the delivery room cuddle as being the calm before the storm before the calm. So Nicodeme, stormy time as any 22-weeker would be, but he eventually got home. He went home at 5.5 months in January 2019. And he had his second birthday back in July, and he's a lovely little lad. And when I asked Sheila what her memories of the delivery room cuddle were, she made these comments. She said, "Oh, I was thinking about the cuddle this morning, and that postnatal fatigue is so tangible even now." And she said to me, how considering how unclear the outcome of his birth was and whether he'd survive or not, I can honestly say that cuddling Nicodeme was probably the most encouraging factor in me deciding to express milk for him. So we want to end our session with giving parents views on it. I think if we're ever in doubts about how important it is, to us it may just seem, oh, quick cuddle for 1 or 2 minutes, a few minutes. But to parents, it's a massive thing. And I just want to leave you with some quotes to emphasize that, if we're in any doubt as to how important it is. So coming back to Josie, who I mentioned earlier, she had 23-week twin girls who did really well. She says, I was and am so grateful to have had that first cuddle and lucky I got the chance. I really hope this becomes a normal thing to have straight after delivering your babies. It's such a powerful connection you have even at that early on time. And I feel that it's part of why the girls have done so well, because of doing as much skin to skin I could from the minute I could. I told you in our survey that we did, we deliberately excluded bereaved parents, although it would have been fascinating to hear from them and what their memories were. But it was interesting, I was presenting this talk a year or two back up in the northeast near Newcastle to the Neonatal Network. And one of the mums in the audience, she actually runs a mental health charity for parents who've had babies on neonatal units. So Lottie from Leo's Neonatal, she actually wrote to me via Twitter, unsolicited, and this is what she wrote to me, and I'm sharing these comments with her permission. She kindly allowed us to share them. So she said, I never got to hold Leo until it was time to say goodbye. She was the mother of 25-week twins, yeah. So Leo was one who didn't make it, and she said, hearing about this delivery and cuddle really struck a chord with me. I think it's such an important and fundamental thing which is expected, to have a cuddle when you have a baby. And when they're born preterm, it's often something parents feel robbed of. I was very affected by that with Leo, and again with his twin brother, Oscar, who did survive and was born 4 days later. So even though she'd never even heard at this time, a couple of years ago, about cuddling babies, she felt robbed of not being able to have that cuddle, things that you take for granted if the baby's born much more mature. So seeing our presentation, she wrote to me saying, I felt a lot of guilt and very angry at seeing those photos in delivery rooms of happy mums getting the chance to have their baby on the chest. But when I heard about it, I thought, finally, this could make a huge difference to parents and to the baby and to the mental health of parents. And being able to reduce that feeling of guilt and grieving over what they've not had with their pregnancy and delivery is going to make a phenomenal difference. So we started this presentation with Emma Allen's work, little animation. And I'd like to end with some of her words, with her kind permission. So she wrote to me, a cuddle is so important. Being able to hold Jack, that's her son who died, right after birth meant the world to me and was so special. And it's the hardest thing in the world not having your baby near you after delivery, and yet you can hold on to that one cuddle you've had. The cuddle I had with Jack when he was born meant so much, and all mums should have this opportunity. So Dr. Corley's already mentioned the first case report of that extremely preterm baby. This is Emma, her partner at the time, and Jack, her little 23-week gestation baby who sadly didn't make it and died of Pseudomonas infection on day 11. Little brother, or I should say big brother of Charlie, you saw on his little scooter earlier. So it's been posted in the chat, the little case report there, and you'll read more about Emma's words and why we all feel that the birthday cuddle is irreplaceable. We've all only got one true birthday in our lives, the day we're born, and so if you don't get a cuddle on that day, you'll never get it back. So we'd like to end this session by first and foremost thanking all our nursing, medical, midwifery and obstetric colleagues in Norwich for great support for this concept over many years. I'd like to pay special thanks and praise to myself and Dr. Cawley. I'd like to thank our co-authors, Emma Allen and Sheila Atuono, for their enthusiastic support, development and promotion of the concept of delivering Cuddle and sharing parents' unique perspective on it. I'd like to thank all the other parents who've so generously shared their quotes and pictures for this presentation. And finally, we'd like to thank all of you for listening in, and we offer you lots of cuddles from the UK. Thank you.
I would just like to take over from here. What we would like to do before we close the session, you've all seen a question box in the menu. So if you have any questions to our presenters, please feel free to type in the questions now. And Dr. Clark and Dr. Cawley will be happy to answer you. So we give it a few moments for the audience to type in their questions, and if there are any, I will read it out to the doctors. Okay, so there's no questions so far, but we just allow a few more minutes for people to type in. In the meantime, I would, of course, once again, as Margarita already said, like to thank Dr. Clark and Dr. Cawley for their wonderful presentation today. I think that was a very great insight and a very, very authentic and realistic insight. I really enjoyed this presentation, and I'm sure the audience did as well. And I would also like to thank Linda from South Africa, who was the driver for this webinar tonight, and for the great promotion she did to get the audience on board. So thank you, Linda. And I'm looking forward to many more valuable presentations with you. I would also like to mention our digital neonatal course that we are currently running together with Linda. She's the main presenter on this, and we have my colleague Margarita speaking on this course as well. I will post the link in the chat box. So if you are interested, there are 8 modules in total. We've already completed 2, but you can see the recordings on our website. And if you are interested, of course, you can register for the remaining 6 modules on that course. So now I see a few questions coming in, so I will read this out to Dr. Clark and Dr. Cawley, and I let you two decide who would like to take the lead on answering. So the first question is, what is a big difference between immediately kangaroo mother care and Cuddle?
So thank you for the question. The way we practice it in our unit is not kangaroo cuddling, it's not kangaroo care. I think that the 2 randomized controlled trials I presented are quite different in many respects from the way we practice it. We're just keeping it simple, really. We're not doing a complete pure skin to skin. It's following on from our normal practice, which has been for many years placing the baby in a polythene bag and swaddling them and getting them stabilized in that way before taking them to the neonatal unit. So we're simply transferring the baby in that state, swaddled in plastic, to help preserve the normothermia. So this is why I think there's a big difference in the babies going right down to 22-week gestation that we're offering it for compared to the others. I think in due course, in the years to come, maybe in the next 5-10 years, that will be the future, and there will be studies looking at kangaroo skin care in the extremely preterm babies, but that's not the way we practice it. It'll be interesting to see. As Paul presented some data, then I think from his observational data that he's got, the mother is a natural incubator here. She's at the right temperature we want the baby to be at. So you can see that's a big driver in why these babies are less likely to get cold with kangaroo skin-to-skin care. But that'll come. I think that will need trials before we can say it's safe to do in the extremely preterm babies. Paul, do you want to add anything on to that?
Yeah, I guess, no, I fully agree. The distinction here is that we're advocating for cuddles for babies that otherwise would be whisked away and put in an incubator. Obviously, many babies can benefit from kangaroo care and receive their neonatal course on the mother. Presently, in most countries around the world, in those that are very preterm and extremely preterm, it isn't feasible, and the resources aren't there to support intensive care whilst on a mother. And certainly there are potential complications relating to thermoregulation of that, although certainly that's where we see this going. But we're advocating for cuddles where normally the mum and the baby would be separated without contact.
Okay, thank you very much for that answer. I have one more question that just came in. Are there any special recommendations for uncomplicated cesarean section deliveries?
Do you want to take this one, Paul? You've
Okay, certainly, yeah.
been through this.
I guess that there isn't, as long as you're working as a team. So where the mother's awake, then there's really no reason why you can't support the deliver and cuddle, but you need the support, particularly of the anaesthetist who's at the mother's side. So it's about removing any obstruction that's going to come in the way between either your resuscitator or your incubator or whichever device you're using to support the ventilation and the mother. But everything else, the monitoring the temperature, monitoring the saturations, can all be achieved during an awake section with the mother. So really the special consideration is that the anaesthetist is happy the mum's stable and you're able to make space to get the baby in without compromising the sterile field, because obviously that's going to upset the obstetricians as well. But yeah, I've done it on many awake sections and had no issues.
Okay, so I believe that was it in terms of questions. There was nothing else coming in so far. Oh, now there's another one coming, so I'll read that out to you now. Is there a specific time recommended for cuddling a newborn who is stable?
No, and I think if it's a new concept to you and to your colleagues and to your staff, then start small, start short, get the hang of it, get the training and practice in place so that everyone's familiar with it before rolling it out. But yeah, start for a couple of minutes, 1 or 2 minutes initially. You'll feel anxious because you've never done it before. There's an anxiety there. I think even now when we're going 5-10 minutes as a routine, it feels odd because we've never done it before, but you will overcome that anxiety with the more you do it and the more comfortable you feel with it, and you won't feel that pressing urgency to have to dash the baby away and stop that precious time. So as we've said, we routinely now do up to about 10 minutes where the parents want that. Sometimes it's shorter because they don't want that longer. They're happy that they've had a few minutes with the baby. There's no set time. It'll vary from baby to baby, parents to parents, and situation to situation. Do you want to add anything to that, Paul?
No, I don't think so. It's really as long as the baby's stable, then that's the main thing, isn't it? And you're offering all the necessary support.
I guess the longer we're there, I mean, one of the things we do need prospective safety data on is the glycemic status of the baby. So in one of the, it is there as an option, you'll see it in Dr. Corley's flow diagrams that you're able to download. There is an option there, much as they did in one of the RCTs for getting a line in and starting some glucose. But there are other options, that there are prospective audits underway now looking at the use of things like hypostop in the delivery room to to maintain normal glycemia in the baby. But I think if the baby's in a decent condition, is kept warm, that's one of the biggest things that is going to keep the blood glucose normal. And you can see that with the little 22-week gestation baby there. He had a nice, very normal glucose level at 55 minutes postnatal.
Okay, so thank you for the questions. Thank you for answering, Dr. Paul. With this, I think we've come to the end of the session today. Thank you once again to Dr. Clark and Dr. Corley. Thank you to Linda and of course to Margarita, who's unfortunately not able now to say goodbye to the audience. I would like to say that we do have a feedback survey for this. So once the session is closed, you will receive a pop-up window with a few questions. So please take a few minutes and leave us your feedback. We would really be keen on understanding what your feedback is for this session, what was interesting for you, what we could improve in future, and what other topics you would be interested in. So please take a few moments and complete the survey. That would really be helpful for us. And with this, I would like to wish you all a very nice evening. Thank you for dialing in. Thank you again for this wonderful session. And I've just, as a last thing, posted the link to our neonatal nursing course into the chat. So have a look. The next module is on the 20th of May. So please register for that. And we are looking forward to welcoming you to our future sessions. Thank you once again. Have a nice evening, and thanks for dialing in and your time. Good night. Bye-bye.
Thank you, everyone.
Thank you.
Bye. Bye.
Bye.
Bye.